And welcome to the Patient Physician. My name is Paul Smith, and I'm joined today by my co-host, Chris Fulbright. How are you, sir?
I am great, buddy. How are you doing today?
Well, I am hanging in there. I'm going to be honest with you. I could probably use the services by the next folks that we're going to be talking to. But I want to just start by saying, our goal when we started this show was to really explore the human side of medicine so that we could share their stories, one conversation at a time. And today we're diving into the world of psychiatry with two clinicians who are still married, actually, but they're reshaping what compassionate mental health care looks like in a private practice. Today we're joined by Dr. Zachary Herrmann and Dr. Sarah Slabaugh, married couple, fellow psychiatrists, new parents, which we hope that they stay awake through this whole episode. Kidding. And they just welcomed their first child into the world. They are very thoughtful, grounded, deeply committed to patient care. And today we're going to explore everything from the evolution of psychiatric practice to the realities of running a modern private practice. So welcome to the show. I'll get into your intros here in just a second, your background, but welcome to the show. How are y'all today?
Great.
Very good. Thank you, Paul.
Tired, but good.
Nice to be here.
It's a break from the baby. Congratulations, guys.
That's right.
That's exciting.
Yeah, thank you. Yeah.
It is a very exciting world. And as you said, very exhausting as well. So is also getting through training, running a private practice and everything else with it. So I've said time and time again, I don't know how y'all do it, but here we go. So Dr. Herrmann is an adult psychiatrist at Bay State Medical Center in Springfield, Massachusetts, where he serves as medical director of the Interventional Psychiatry Service and is an assistant professor of psychiatry at UMass Chan Medical School, Bay State. Dr. Herrmann has extensive training in emerging experimental treatments, including psychedelic-assisted therapy and ketamine-assisted therapy. He is also an apprentice in Groff Breathwork. Did I say that right? Groff Breathwork. Yeah. Okay, good. Dr. Herrmann has a strong interest in therapeutic potential of non-ordinary states of consciousness and their ethical and person-centered application. His better half, Dr. Slabaugh, is a child and adolescent interventional psychiatrist serving Western Massachusetts through Bay State Children's Hospital, UMass Chan Medical School, Bay State. She consults across hospital, emergency, and outpatient settings and is involved in teaching trainees across 4 disciplines. Her training includes internal medicine, adult and child psychiatry, as well as educational and psychedelic therapies, ketamine, cannabis, cranial osteotherapy, and also Groff Breathwork. I'm going to need that after this great intro. So
just focus on your breathwork.
I know.
It's all breathwork.
I should have taken that as training. Her clinical focus centers on transitional aged youth, treatment-resistant depression, family systems, and whole person wellness. Together, Drs. Herrmann and Slabaugh own HS Psychiatry, a practice focused on the only form of psychedelic-assisted psychotherapy that is medically available, ketamine-assisted psychotherapy. They have collaborated on research projects studying naturalistic prescriber psychedelic use and experiential measures in psychedelic research. At the heart of their shared work is a commitment to trusting their clients' own inner wisdom by providing a safe, supportive, and compassionate environment. In doing so, they aim to cultivate a sense of clarity and connection to oneself and community. And thank you for your time. That's it for our show. I'm kidding. But welcome to the show.
Thank you very much, Paul.
Thanks.
Thank you for the nice introductions.
Yeah.
It was very kind to hear.
I'm wondering if I should have edited a little heavier for that. There was a lot of alliteration. I wasn't aware we were making you guys do.
You know what, though? That's the whole purpose of this. We don't want to edit down all the achievements and the things that you've gone through. You know, Chris and I started this because we wanted to give this platform to say, hey, this is what we went through just to get here, and now life begins. So that's actually a great place. Let's start at the beginning. So Zach, Sarah, what drew each of you to psychiatry first, and how did your paths even converge, and then ultimately now to start HS Psychiatry?
Yeah. You want to share your
You go ahead.
You know, I think I can speak for both of us pre-med. You know, the idea is let's do something helpful, let's do something interesting. You know, let's make a decent living, but most importantly, let's help some people. And I think that's what attracted us both to medicine. we met in our first year of med school, and I was painting Sarah's apartment. I was helping her paint, and she asked me, she said, "Have you heard of this thing called MDMA therapy for couples?" And I think at the time I was like, this was 2012, 13, yeah. And I was like, I don't know. It sounds like it'll melt your brain or something like that, you know. Just
That's an interesting first date, probably.
well, I was watching paint dry, yeah.
As soon as you're done painting my place, let's head to some therapy.
Let's do some MDMA therapy, yeah, for sure. You know, save ourselves some bills down the line, some therapy down the line.
That's right.
Yeah. I had actually read this article in, like, I think it was Oprah magazine before even med school, where they had talked about some of the underground work that was going on with MDMA-assisted therapy in the trials that was happening at the time. So that was out of South Carolina, as well as a whole sort of cadre of therapists that were using it illegally, but using it underground as a therapy adjunct. And all I kind of knew about MDMA was that it was drugs and it was bad and it was going to melt your brain. And so I had read this article and I was really intrigued. And so we started talking about it, and both as we kind of evolved in medicine and in med school, kind of started finding the original studies, started following the work of MAPS, or
more articles just started flooding.
Right.
Every time you turn on the news, this was 2015, 2016.
So this was so How to Change Your Mind came out in 2016, which is when a lot of the press coverage really shifted and changed, and it really exploded. So pre-2016 was when we were kind of reading about this and trying to connect more within, like, the medical community to understand how do you work with this. But it was really confined to phase 1 trials at that time.
Phase 2, but yeah, I mean, just early trials. And for people out there who don't know, How to Change Your Mind was a book written by Michael Pollan. And Michael Pollan wrote The Omnivore's Dilemma. So he's a fairly well-known author. But that book, How to Change Your Mind, came out, and it was all about psilocybin-assisted psychotherapy. So, and psychedelics in general. So it was kind of a big moment in, I don't know if you guys have heard the term, the psychedelic research renaissance or something like that.
I was just using that phrase this morning.
Basically, there was a lot of research in the 60s. It went dormant, and then into the 2000s, somewhat in the 90s, but really into the 2000s, it blew up again. And Michael Pollan's book was the first book that you could just find in anyone's house, right? He wrote all these books that weren't about, you know, anything related to drugs necessarily. And then all of a sudden, this well-known author writes this book, and you can go to your neighbor's house and you'll see it sitting on their desk. They're not in psychiatry, they're not in, you know, medicine. And so that caught a lot of attention. So what happened was, in third year or fourth year of medical school, you start to think about what specialty you're going to pick. So Sarah and I had continued to read up on these trials that came out, with these articles that have come out, books that came out, whatever. And we continued to stay very interested. And then eventually you find your specialty. And long story short, we both ended up in psychiatry and just continued an interest in this area. I think that about sums it up. What do you think?
Yeah, I think what was kind of, for me, I actually went to medical school wanting to be a surgeon. And so surgery and psychiatry, it's kind of interesting. If you ask psychiatrists that, there's a surprising number of us who say, yeah, I wanted to be a surgeon at one point. Oh, wow. But one of the things that really drew me was this work. And I really did feel, you know, this is just my personal opinion, but I felt like psychiatry was kind of similar to where surgery was some, 50 years ago, where we're going to see a lot of change and a lot of evolution because of the tools that we have coming forth. So that was one of the reasons I chose to pursue psychiatry, was to hopefully be able to work with these compounds for patients.
Yeah. Well, now you're just operating on somebody's psyche.
Exactly. So chill.
So that's, yes, I've heard that metaphor, Paul, but to be honest, it's actually not a great metaphor to use for this world, and I'll just throw that out there, and we can open up and unpack that. But that's
I didn't mean to use it in that very liberal way, but it just as a joke. But you both went the DO route, so I am kind of curious, how much of this were you researching on your own, because there wasn't a lot, and then how much of it were you exploring and starting to go find, but how much of it is actually taught through your training as a formal piece?
Yeah, therapy in general. If you go through a psychiatry residency, you're going to learn therapy. And I don't think psychedelic therapy is that dissimilar to just conventional therapy. But it's important, I think, just to name this. It is one thing to call something a treatment, and it's another thing to call it like a wellness, a pursuit of wellness or betterment. That doesn't necessarily mean it's a treatment. So we don't get any training in medical school, at least when I was there, for psychedelic treatments. Mm-hmm. And ketamine, while technically would fall underneath a treatment, it hasn't really been identified really well for mental health conditions, but we still use it off-label as a treatment. So to answer your question, Paul, at least when I was there and Sarah was there, we didn't really talk about this at all. In fact, I think her and I were the ones that were really like, hey, has anybody else been reading this really compelling data? This is pretty interesting. We should be paying attention to this. There's a mental health epidemic right now. A lot of these treatments, I'm not a psychiatrist yet, but I do know a lot of people don't benefit from a lot of psychiatric treatments. So, eventually you have to find non-ordinary states of consciousness is a broad term. It doesn't just mean psychedelics. You can have a non-ordinary state experience with breathwork. So I think over time we found ways that were available to us legally and literally to explore non-ordinary states of consciousness. And what we've learned over time is there's not a lot of difference between a non-ordinary state of consciousness from breathwork than there is from psychedelics. There's some nuance to think about, but it is okay, I think, to think globally about non-ordinary states of consciousness in general, and then how they could how they could be treatments or how they could be, used for wellness and things like that. So would you add anything?
Yeah, I mean, I think that Zach is also kind of saying that is partly how we got here. So, as we're going through training, there aren't treatment. We're not being trained on, can you prescribe psilocybin for depression, right? Mm-hmm. We're being trained in conventional therapy and conventional prescribing. We had this additional interest that we were building. We chose to continue to get training while we were in our psychiatry residency. Our training program was very generous with us and allowed us to pursue specific training in psychedelic therapy and research, which was offered through a different accredited university. But this was purely of our own interest. And I think as we've continued to educate ourselves and know the data, to Zach's point, that's where this gets really confusing from a clinician perspective, as well as in the treatment room, which is psychedelics as a treatment for anxiety and depression are not FDA approved at this point. Everything is still under investigation and under trial. However, we have this huge movement, right, where people are talking about microdosing mushrooms and microdosing psilocybin and using ketamine. And they're saying, I'm treating my depression and my anxiety, which might not be, as a physician, that's not necessarily how we view it. You're doing this for wellness or for your own cognitive enhancement or for your subjective sense of wellness. But this isn't something that we can say, definitively as a treatment for anxiety and depression. And so that's really where I think our practice focuses and where we as educators focus, which is there's a lot of interest, excitement, information out there, but it all kind of gets hung under this umbrella of psychedelics. And we're really trying to help physicians as well as our learners really understand the different kind of schools of thought and approaches to help it become less confusing for patients. So if a patient does walk into your room and says, I'm using mushrooms, where do you as a clinician begin without saying, stop, that's bad? So you can come from a perspective of curiosity, so they'll share more with you as opposed to shutting it down, just because that's not something that we were trained in, if that makes any sense.
Really, to say it bluntly, the difference, oftentimes, the difference between a treatment and a modality for wellness is hundreds of millions of dollars. It might very well be that people are benefiting from microdosing for a psychiatric condition, but until a lot of resources have been spent researching that to prove it beyond a
statistical certainty.
To provide statistical certainty and safety data, we can't say that it's a treatment, and oftentimes it does boil down to a lot of money. So that's kind of a big issue in the field at large too. So,
where are we in relation to the FDA? Sarah, you brought up the FDA approval, and where are we in that spectrum? Because when y'all started, it's like, hey, it became very popular in the '60s, cycled down, coming back up at this point. Can y'all kind of talk to that story and share with us kind of where we are on the FDA continuum there?
So psychedelics and consciousness altering agents have been around for as long as humans have been around, right? And we know that by looking at historical data as well as archaeological data that people have been buried with different psychedelics, and these have been part of sacraments. These have been something that have been throughout history and time. About 100 years ago, there became more interest in Western medicine through religious experiences, William James and other people of religious order that began bringing this more into medicine, this interest in consciousness altering agents. So they were looking at mescaline, they were looking at nitrous oxide. So that was before the turn of the century, so early 1900s. LSD was developed back in the 30s, actually, as a drug for hypertension. It was put on the shelf, wasn't researched for some years. Then in the 60s, the chemists that developed it noticed by accident that there was mind-altering effects. And then LSD was actually, or lysergamide acid, is being sent out to doctors as a sample to like try it with therapy. It's just being sent out as a drug to kind of see what kind of use you can get out of it. So a much different regulatory environment at the time. So this is in the 60s. In the 70s, so some research was done. This is actually, LSD helped us develop our understanding of the current model of schizophrenia and treatment. So it helped develop the monoamine hypothesis of psychosis and schizophrenia. It was being used to treat alcohol use disorder at the time, but unfortunately the studies were not double-blind or placebo-controlled, so it was all kind of open label and observational. And so in the 70s, when the Controlled Substances Act came around and Richard Nixon put LSD and MDMA and others as rated them as Schedule I substances, all of the research shut down at that time. So from about the 70s to the early 2000s, there was really no psychedelic research that was happening at the time because they were Schedule I. And what Schedule I means in the eyes of the government is that they have no research potential, they have no medicinal potential, that they are drugs that are just going to cause harm. So no research was going into them. In the early 2000s, there was some work that was revived around this really slowly out of Arizona. And then since the early 2000s, they have been doing kind of more and more research. MDMA specifically, or ecstasy as some might know it, was being championed by the Multidisciplinary Association of Psychedelic Studies, or MAPS. And they had submitted for FDA approval last year in August, which it was, their application was rejected. So there was a whole kind of wave in medicine, as well as, kind of in the psychedelic world. There was this thought that approval was going to happen and that was going to largely really shift the landscape. And it did not happen. I'll let Zachary kind of share more thoughts around why that did not happen and what that landscape is.
So I don't know, did you guys catch wind of that? So the study, the drug MDMA, which is better known as ecstasy, but ecstasy implies like impurities, so it's usually combined with stuff. But MDMA is the molecule that was being studied. And so, as Sarah mentioned, we were researching MDMA therapy for PTSD, and in August, was it August this past year? It seems like so long ago. No, it was the year prior, believe it or not.
Oh my gosh, that's right. I was pregnant with a baby this past August. That's why it's all together.
Anyway, in the last 2 years or so. It did not happen. MDMA was declined approval for the treatment of PTSD. And some of the reasons were the confidence wasn't there that it was effective. Number two, the confidence wasn't there that they had assessed for enough harm. And number three, probably had to do with their enrollment. So a lot of people that had participated in the trials had actually taken the drug themselves. So there was some, not great research methods there. And then number four, it's probably out of the purview of this conversation today. I'm happy to talk about it, but there was a very serious incident that happened in a site in Canada where after the study participant went through the protocol, she continued therapy with this couple out in Canada, and they ended up having a relationship. The male therapist, who was not licensed, it was pretty terrible what happened. And so all of that kind of culminated at the same time, and there was kind of a big anti-MAPS campaign going at the same time. So the end result is the issues that were identified were insurmountable, at least according to that FDA. Interestingly enough, if it went through approval with this FDA, it might have actually been approved. So I think it depends who you talk to about the nuances of the research and the data. I still think there's a world where it could have been approved, maybe on a limited basis. But unfortunately, that was in 2024. They're back to the drawing board, but the FDA basically said, do another trial and we'll get back to you. But doing another trial, fixing these deficiencies that they found, that's hundreds of millions of dollars. So it's not, and this is a nonprofit organization. So it seems like eventually they'll get there, but there's a lot of work to be done. On the depression side, this is a bit more recent, Chris. There's a company that is developing psilocybin for the treatment of treatment-resistant depression. So that's like someone who has clinical depression that's failed at least 2 treatments of a typical SSRI. So they're developing, again, psilocybin for assisted therapy for the treatment of major depressive disorder. And they're in a phase 3 right now. And last I heard, actually, it was like last week or something, they're hoping to seek approval by the end of the year, which was pretty surprising. I thought, if anything, it'd be in 2027. But what I want to kind of highlight the differences between these two drug developments. On the MDMA side, they really focused a lot more on therapy. On the psilocybin side, they're really focusing on safety and support, but they're really looking at it more like a biological treatment. So we'll keep you safe, but does the drug, just by being in your system and then leaving, do we get a positive biological response, improvement in your depression scores? That is pertinent, right? Because in a typical trial, if you're trying antidepressant, usually you'll get 30% reduction. At least 30% of people will improve as a function of placebo. The drug companies right now are trying to say, well, if we optimize the safety for psychedelic treatments, maybe not so worried about the therapy, but optimize the safety, can we get 40% or 50% improvement? So the difference there is 10 to 20%. That's a significant amount of positive results, and that has a lot of implications for drug development and profits and all that stuff. So it looks like they're really trying to capitalize as much as possible on that minimal amount of intervention and get that any antidepressant effect. But it is a little bit different, I think, than how the developers of MDMA were approaching it, where they're really more focused on the therapy and kind of using the drug to enhance the therapy a little bit. People probably have different opinions about that, but that's kind of the landscape as it is now. Chris, hopefully that kind of addressed your question there.
I love framing that up. It helps the conversation. I'm curious, and I don't want to take y'all down a road that you're not comfortable going down at all. So
happy to go anywhere.
Are the companies that are doing this research, are they traditional medicine companies? They're the ones that are already making the pills for the same type of PTSD and other items, and this is an alternative to something they currently have? Or, as Sarah mentioned, this has been around for hundreds and hundreds, if not longer, and we're pulling this experience forward and saying, okay, now based off of the FDA rules and regulations, can we clear this for, I don't know if I should say treatment or well-being, treatment. Yeah.
Treatment.
So are we dealing with the albatross of the current pharmaceutical companies this is a competitive type thing to them? Or are we trying to validate truly and saying, based off of this, let's use historical data and move forward from there? Again, I don't want to get if this is that's a dangerous knife edge we don't want to dance on. I understand.
Unfortunately, there's no really historical data that meets today's current standards of data.
Okay, so that's what it's the FDA standards currently that we're trying to, the safety protocols that we're trying to match. Okay.
They're not traditional pharmaceutical companies, that are that we know that you would recognize their names, if you're listening to the radio. These are pharmaceutical companies that were founded and kind of designed around the idea of bringing these to market. So MAPS specifically, they were the ones that were trying to bring MDMA to market, and they started out as a nonprofit that then became a public beneficiary company that then became a company. But that's saying they've brought in kind of like traditional pharmaceutical staffing to try to help bring them to market. And the other company that is close to bringing a psilocybin derivative to market was also designed around trying to bring them to market.
None of the big companies are involved right now, but they're curious. There is a form of ketamine on the market. Its generic name is S-ketamine. That is marketed by a big pharma company, but it's a very biological model. And what that means is, again, but just by nature of the drug going in your system and leaving, do we get a benefit from anything, depression, whatever? We are much more aligned, and I'm interested in the biological model because it's important, but Sarah and I are much more aligned in therapy. If we get a biological effect and you get a biological antidepressant effect, great, awesome, but I think there's a lot more we can get if we use certain therapeutic principles. So that S-ketamine, that ketamine derivative that is marketed by a large company, they're not looking at that at all. They were very much all right, we'll put the drug in your system and hopefully you get benefit. And there's compelling reasons to do that. I mean, there are people who get really good relief just from getting an infusion or intranasal treatment of ketamine, once a month, once a week, whatever, and it can make a world of difference. So I don't think I'm inherently opposed to that. I just think there's a lot more nuance to think about to kind of really maximize and then make the most out of these experiences.
Yeah. I do think it's worth mentioning, Zach kind of touched on a little bit in the models. So there are different models of treatment. There's, as he mentioned, the biologic model. You take a medication for the disease. We want it to have a biological effect. There's also the psychedelic model, which is where we're giving someone a medication with the intention that they will be able to go within and have some sort of self-exploration. And then there's the psycholytic model, which is a therapy model where someone is taking medication to help soften their ego defenses in the therapy session, but that they are fully engaged, fully interacting, and it's used in such a way to enhance therapy.
Yeah.
And that's the model we practice under in our private practice, which is the psycholytic model. This is pertinent to what Zach mentioned in that what model you're using, whether it's biologic, psycholytic, or psychedelic, does inform the way you think about medications. Something like esketamine, which is used in a biologic model, the package insert has side effects such as euphoria and other things that in a model where, say, it was more psychedelic or psycholytic, you might just consider that, an effect of the drug, but not necessarily a side effect or something that has to be managed.
Yeah.
And so that's where you guys are doing the assisted. That's where the assisted psychotherapy comes in. What does that kind of look like, where you're assisting them through that experience?
Yeah.
Is that a good way to describe it?
Yeah, Paul, let me give you kind of an overview, and you can really apply this to any molecule. Again, this is really a therapy model, and we're using a molecule to kind of like enhance that. But basically, you want to spend a lot of time in preparation. So the idea of preparation is building trust, building comfort, so that when the patient is under the influence of the treatment or the molecule or the drug, whatever, they'll feel safe, hopefully. They'll be able to kind of like go into the experience. And oftentimes we will prep people by saying, hey, we're going to have music on. Let's put some eye shades on if that feels comfortable to you, no pressure. But oftentimes we would recommend that. As the substance, the ketamine kicks in, like let's just kind of like go into that, close our eyes, kind of listen to the music, let it carry us away. And the whole point of this is that when the session, so that was preparation, when the session does happen and someone can hopefully go inside because they feel safe and they feel like they can trust what's happening, they can connect with their own inner resources. So there's a term that gets thrown around called the inner healing intelligence, which is a way to name it. But what I really think about it is the psyche, a person is able to heal. A body is able to heal if it's just held in the right way. And I think the psyche is very similar to that. For whatever reason, it can kind of get bound up. And so if we can help somebody just kind of like engage beyond that, where that knot is, kind of below that level, if you will, kind of below those defenses, if you will, and they can kind of tap into their own humanity, their own experience, their own feelings, their own connection, their own spirituality, all the stuff that I won't tell people what's gonna happen because they'll figure it out for themselves. But those are the themes that come up. What naturally seems to happen is their psyche just kind of leads them down the direction they need to go. So maybe they run into something really scary, like a dragon, like they're visualizing a dragon. We would say, go ahead and fully experience the dragon. Let the dragon swallow you. You're not going to physically die. You might feel like it's a really scary experience. You might feel like there's a psychological death, if you will, but physically you're totally fine. And so like, let's let that dragon kind of like do its thing and kind of embrace. And maybe, and I wouldn't say this, but like maybe someone, they are swallowed by the dragon and they kind of disappear. But what they find on the other side is maybe all that fear kind of turns into love, or maybe they find a lot of sadness over it and then it jumps into anger and then it jumps into love. But the point is like, we're just letting the person's psyche kind of direct the show. And it often correlates with maybe some imagery that they'll see. But again, it's really about that preparation is really about for when you're in the session that hopefully someone feels comfortable enough to kind of go internal and kind of explore what's going on. And then the last phase of any psychedelic therapy would be integration. So that's really making the most of what you just experienced, talking about it, processing it, integrating it. There's this phenomenon known as state-dependent learning, which basically means that if you're under the influence of anything, you're more likely to remember and understand what that means when you're under the influence. So to make that practical, if you find that you're an accountant and when you drink coffee you're way better than numbers, you might think back and realize, in college I drank coffee every time I was cranking out these calculations. Maybe that's why I'm just better at it on caffeine in the present. Mm-hmm. That's called state-dependent learning. And I think psychedelics are no different. You can have these really big, ecstatic, often scary, often amazing, whatever, all these different possible experiences, but it's happening under the influence of the drug. So integration is really kind of like acknowledging that was an experience that isn't, you can't live like that every day, but how do we take that experience and make the most of it? How do we integrate it into our being, into our psyche, into our soul, into our relationships, into our everyday? It's really easy to avoid stuff. We can have these big insights and be like, I don't know, I'm really angry at a sibling. But if you don't do anything with that, I have these feelings, I'm so angry and I feel them right now. And now the session's over and you're like, well, that's out of my system. I don't need to do anything about that. There might be more there where you can talk about it and process it in a normal waking consciousness state of being and kind of, integrate the most of the experience. Mm-hmm. So that's kind of the
people remember that? Like, so when they come out of this, like, do they remember in your example, the dragon, they're conscious of what's going on, communicating with you, and you're guiding them through it or talking, but they remember that Okay. Is this adult specific? Can you do it with children?
18 plus, right?
So what I will say about remembering, yes, you can. One thing to keep in mind with ketamine is it is not a typical psychedelic. It has an amnestic quality, which means people can forget stuff. And that's kind of one of the downsides of ketamine, is that because it kind of causes some dissociation, you don't get like kind of the full interfacing with what's going on. On the other hand, it's a lot more tolerable than something that doesn't have a dissociative quality. So yes, Chris, most of the time people do remember, but with ketamine, people, their memory can get a little hazy, and that's something that we often have to work through.
Actually, really interesting. Before I get into the child, I want to say there's an aside that actually is interesting, which is Chuck's data. So there's one of the research groups is doing some research about like psilocybin, and essentially they're giving someone a benzodiazepine in increasing doses just to help them not remember. And really their question is, do you have to remember the experience for it to be sticky, or for it to have some sort of lasting effect for the person? And what they're finding is that taking a little bit of the edge off with the anxiety makes it more lasting for people. And B, the people that aren't remembering, they're having spontaneous experiences in some of the days following. And so we really do have a lot of questions. And this is why it is such a confusing field as to like, how does this work? How much remembering does need to happen? There's a lot of money that's being thrown right now at, can you trip without tripping? Can we develop a psychedelic that we don't have maybe a hallucinogen experience, or we don't have an experience, so it makes it more maybe psychologically safe for the more maybe complex, mental health patient, but we don't have an experience. And is that experience necessary for that lasting change is some of the questions that we have right now that are trying to be answered.
Probably the biggest question in the field right now. Do you need to have a trip to have any benefit?
Do you have to trip to trip?
Do you have to trip to benefit, basically? Yeah. And the data Sarah mentioned, very interesting data. I mean, it was a small sample, but I think it is definitely very interesting to read about.
But to answer your question about kids, children and adolescents, so the big picture is no. All of this is being done on 18 and up, but with some exceptions. So currently, there's a study at UCLA that they're trying to enroll for treatment-resistant PTSD, 15 or 16 and up. So for MDMA, for treatment-resistant PTSD for children and adolescents. And ketamine is legal and prescribable for a child of any age. We actually use it quite frequently in pain management and in pediatric emergency medicine. So, if your child has gone to the emergency room and maybe had their arms set or had some sort of procedure where they needed conscious sedation, ketamine was probably used. It's very safe. It's very effective. So we use it on all ages for non-psychiatric indications. For psychiatric indications, again, all generic ketamine is off-label prescribing. 40% of the prescribing we do in psychiatry is also off-label. So that said, so there is a study that has been done about IV ketamine, so receiving an infusion of ketamine versus a placebo. Does it help reduce adolescents' suicidal ideation? And the literature found that yes, it did. This was done out of Yale with a group at Yale that was doing the initial research with ketamine, and that takes a lot of money to do these studies when we don't have a drug that's necessarily patentable on the other side to recoup that money. And currently, ketamine, as we use it, we're using a generic version, very inexpensive, and it's not patentable, meaning there isn't anything unique about it that a manufacturer can patent it to kind of recoup large amounts of money. That has been done with some versions of ketamine where maybe it's a novel delivery system or something of that nature, where then that's something that's patentable that they're able to recoup that. So it is being used on children and adolescents. We have some data for the biologic. There are clinicians that do use ketamine-assisted therapy for children and adolescents. Most of the people I know that work with this group usually do 12 and above. And it's usually cases where they're quite treatment refractory at that point. These are children or adolescents, I should say, that, usually have tried multiple drugs, have done multiple kind of different treatments, maybe have had multiple hospitalizations, have been in care for some years, where they're then using ketamine-assisted therapy to help them work through that. There's also some literature with eating disorders as well. But again, children are a vulnerable population, and that plus the funding issues make this pretty challenging to study for children and adolescents.
Kids are so psychologically flexible still that, the idea a compound like this is to kind of engender psychological flexibility in an adult. You don't really need to do that for children often. She might have a different psychiatrist. I'm sorry, I threw it out. But the point is that
you guys argue that later.
there are definitely cases where I think children and adolescents get benefit, but I do think that's a big difference between kids and adults.
I think there's just there's a lot more factors for children and families that you have to consider that make it more complex to deliver.
Yeah.
Sir, you mentioned a second ago about just using generic forms of it. I don't know where it falls in the insurance. Is it, are all your patients cash pay right now? Where is this in the insurance spectrum? Is it covering any of this?
That's a great question. So, no. The short answer is no. The short we as a practice are cash pay only with sliding scale to try to be flexible for those who are not able. We also are able to give a super bill to remit to their insurance if they have out of network benefits. The challenge being, unfortunately, because we are Medicaid providers at our main and primary job, we are not able to actually even see people that are on Medicaid because that is against the rules.
In our private practice.
So, right. So if we see somebody in our private practice that we want to slide all the way or, give very reduced fee, we are not, by law, we are not able to. Even though there's not another place for them to receive this, right? Even though it's not like there's somebody else that's serving Medicaid patients that, we're then taking. So it's really unfortunate because that's a huge part of the patients that really need it. We aren't even kind of allowed and able to serve. If somebody is on Medicaid, that's where the brand name version of ketamine is a good option because that is covered by Medicaid with reimbursement. Generic ketamine, so generic when we're getting an IV or the kind of therapy that we're doing with sublingual lozenges.
Could be sublingual or intramuscular.
It is not covered, unfortunately, by insurance.
So I want to come back. When I hear things like PTSD, it reminds me of a young woman we used to work with years ago. I was telling Chris leading up to the show that reminded me about that. And her husband was ex-Navy SEAL. And she just happened to share that, hey, he's looked at several different methods. And one of the things that he was experimenting, trying to go through for relief was actually having to travel to Mexico to get treatment. And this was probably a decade ago or more, Chris.
10 years ago, yeah.
And so it just makes me think about how people in general are just coming to psychiatry after these long, difficult journeys, and everybody's path to you probably looks a little bit different. And hearing about something like this, and it isn't the normal thing that people probably go in and see psychiatrists. I'm just wondering since this is all you do, you don't do the traditional psychiatry and medications, how you're evaluating somebody that may be a good fit or not for treatment or the therapies.
We both see conventional patients. I mean, the majority of my time is at a hospital. I would like to do more private practice time, but for a number of reasons, it's just not feasible at this point in my life. But, so I treat PTSD patients all the time with conventional medication. I recommend therapy. The issue with PTSD is, at least for medication, there's only 2 that are on label, and I think maybe a third one's coming out. So we don't really have good treatments. Oftentimes I'll have a conversation with patients that I get really attached to. I see how they're suffering, and I'll try everything in my bag. And it's like, well, we've tried the couple meds. What you're experiencing, unfortunately, is the limitation of general psychiatry with PTSD for treating this condition. So we can try off-label things. So that's the med side. So it's pretty easy to get into I need to try something else medication-wise because the only 2 things that are on label aren't working. And we try all this off-label stuff, and that has mixed results usually. So then people generally start to look for other modalities. What I do want to emphasize about PTSD is there are really good treatments, and they're psychotherapy. They're studied, they're tried and true. The issue with these psychotherapy treatments they're really hard to tolerate. So your dropout rates are 30, 40%, I think. So in my mind, if I have a treatment where 30 to 40% of the time the patient can't tolerate it, it's not really a great treatment. And the reason my understanding is they can't really tolerate it is because it's just really distressing to talk about this stuff. And not to mention, it's not just like in a vacuum. Oftentimes people have childhood trauma that's kind of bleeding into their index trauma that they're talking about. So it just gets really difficult. Now, for the people that, are able to tolerate it, they do pretty well. But a lot of people don't. So I hear about veterans all the time going down to Mexico, and they come back with these really miraculous stories. To the credit, I think it's the Texas University system, UT system. I think they've got funding from the government, state government. They're starting to study, at least observationally, before and after, like what's happening with these veterans. And again, not surprisingly, this data always seems to look pretty good. It's just like we haven't really done like the rigorous, like double-blind, placebo-controlled trial. So I suspect you're going to see more of that. Positive observational data. We just need to do actual trials. Paul, to your question about who do I look for in a good candidate? I mean, I want to see if someone has tried some other things. And if they haven't, then it kind of like raises like your confidence. Although the risk is going up a little bit because they're trying off-label stuff, you've tried a lot of the on-label stuff, so this makes sense. Mm-hmm. I want to know about suicidal history. It's one thing to have suicidal ideation. It's another thing to have multiple attempts. That's kind of a different thing. And I'm not opposed to working with somebody like that, of course, but it just raises your index of worry. You're making sure that supports are in place, making sure that you're talking about past suicide attempts, things like that, so that we have a safety plan in place. I'm definitely looking to screen out psychosis or often bipolar mania. These are really extreme kind of conditions. As of right now, I would be really hesitant to try any psychedelic treatment on someone with a history of psychosis or bipolar mania. There might be a day where that changes, but that's kind of our riskiest situation. And just, I don't know anyone, honestly, who would work with that population with ketamine. There might be someone out there, but I think when you're looking for big screeners to get to screen people out, those are big ones, psychosis and mania.
I would add for me, kind of like thinking about like attitude, what's like making a good candidate, really cautious about people that are wanting to approach this as a one and done or a quick fix or like, that kind of has some of those preconceptions about psychedelics. Like I'm going to do it and I'm going to be healed. It's a tool, just like all the other tools we have in our toolbox. It's a tool. This is not going to magically heal anything. So really someone sort of like curiosity towards their experience, kind of like curiosity towards what it might be like, and openness and flexibility around that, as opposed to having a predetermined outcome, a set outcome fixed in their mindset of what this is going to accomplish for them. The other thing is wanting to have like the psychological flexibility and curiosity about their own inner world and experience. One of the things I think that is key for this is Zach mentioned suicidality. And so somebody really needs to be in a place where you can genuinely talk about the fact that progress might happen first through regressing. So you might see some things get worse. We might see some of these old patterns crop up, maybe some suicidal thoughts or some of the targeted behavior that we're working on, that you really see your depression or your PTSD as signaling that it's getting worse. That's something that we really try to talk about and prepare people for. If you are not in a place where you can potentially tolerate some level of regression or distress or things getting worse for you, then you are not in a good place or in a helpful place where this could potentially be helpful for you. This is, in a really a place where it could potentially be harmful. Does that mean you're never going to get there? No, absolutely not. That's where that preparation comes in. We can extend that preparation. We can work on resourcing and psychological safety and how to have coping skills for if these things do come back so we don't have to engage in them. So there's things that we can do, but to say somebody's kind of ready to move to that next phase or that it might be helpful for them is really about some of that ability to regress before they're able to progress.
It's not unlike conventional therapy. I'm looking for a goodness of fit. I'm looking for someone who's, like Sarah mentioned, psychologically minded, is able to reflect. The most important thing with any therapy is what's called a therapeutic alliance. Can you show up and feel, connected to your therapist? You're probably going to disagree with your therapist. In fact, I think with good therapy, that's going to happen inevitably. But can you feel safe? Can you show up each time? You feel comfortable with them? If that therapeutic alliance, or that quality is not there, I would not proceed with the psychedelic therapy treatment, because anything that's happening beforehand is just going to get magnified underneath the effects. So all of a sudden, not only am I now, their mean father, but now I'm their traumatizing father while in the session, and it kind of takes on a life of its own, and it's an unnecessary thing to happen. It could happen. Like I wouldn't say, all right, if it did happen and I missed it, I'd be like, all right, well, let's grist for the mill. Let's work through this type of thing. But ideally, we would kind of catch that stuff early on, and as Sarah mentioned, we could spend as much time preparing as necessary before someone feels comfortable and ready to go.
It almost seems like what you described, and if I'm repeating this back, my understanding is wrong, please tell me, but it sounds like you're really looking for people that are after that tilt towards wellness rather than just fix it, just give me a pill and then I can be on my happy way. Right? Really looking to understand and have this ongoing wellness maybe.
One of the things that we've been kind of curious about, and this we got into in that review paper we did around prescriber wellness, which is this idea that possibly, and this is, we don't know if this is true or not, but possibly are some of the ways that these treatments work, is it that people have a subjective change in their wellness? Can someone have the same depression score? Can someone be, similarly or same depressed, but because of their sense of wellness or their subjective sense of wellness, that they hold it differently, they relate to their symptoms differently, and their quality of life actually goes up? So that's not to say like that's what we're looking for in a client, but some of that curiosity around how can I change that relationship to my symptoms, yes, that is something we're looking for. And that can, we speculate, can lead to improvement in outcomes.
We always have an identifiable diagnosis, so we're not going to treat it. We don't treat something that doesn't exist, right? So if someone comes to me and says, I don't have any issues, but I just want to work on my wellness. Can you prescribe me some ketamine? Absolutely not. That's not going to happen. However, I would tell that person, you know what? There are great ways to experience non-ordinary states of consciousness that are in the service of wellness. Many of them are out of the country, but in the country, you can do things like Groff breathwork. Certain types of sweat lodges, certain types of retreats. Sweat lodges are getting a little bit out of my cultural appropriateness, I will say. But if you were invited to go to a sweat lodge, that would be an example of a legal way to experience a non-ordinary state of consciousness in the service of wellness. Meditation retreats are really popular, 10-day silent meditation retreats.
That person that's coming and asking about wellness, I think it would really be educating them about non-ordinary states of consciousness, and that substances are one way to get there, ketamine being one of those substances, psilocybin being another. But there are other traditions which have been around for as long as substances that Zachary's referencing that people use for non-ordinary state work to progress towards wholeness and to, improve their wellness.
Self-discovery, wellness. You can call it positive psychiatry if you want.
Tell me about the Groff breathwork, because that's something that's come up a couple of times, and you both worked on. I have not heard about this. Obviously, is that something we can all practice, or is it something you have to also take people through an assisted, or how does that work?
I'm really glad you asked. Truthfully, so we so Groff breathwork. There's another name for it called holotropic breathwork. There's been different organizations that popped up, but they're offering the same thing more or less.
And then note that we'll come back.
You know what? This is for the record. This is the first time we've had spouses on together, and I love it.
I'm loving this vibe. This is perfect.
I know. Every time we can see her looking.
I don't know that I'd say that. Yeah.
Sarah mentioned earlier there's a lot of research in the 60s and the 70s with LSD. There was one guy in particular named Stan Groff. He was an MD. He was a psychoanalyst, and he had a very profound experience on LSD really early on when this research was occurring, and it kind of changed his entire trajectory of how he wanted to be a psychiatrist. And I think he might have not completed psychoanalysis or something like that, but eventually he landed in the United States and Maryland at the Spring Grove Hospital and conducted between 3,000 LSD psychotherapy sessions and observed a total of 5,000. And he prolifically wrote about this after everything was shut down. And then he realized, well, the government's not going to let me continue my research, so maybe there's another way to kind of engender these non-ordinary states of consciousness. And that's when he went on a sabbatical, I think, and spent a year or so kind of reading about other cultures throughout time. And he realized one thing that was really common is people use the breath. They would use the breath in rituals and traditions. So he developed Groff breathwork. And essentially, there's like 5 components to it. You're in a community setting, which is really important. So there's you and usually 30 other people. There's usually 4 facilitators, something like that type of ratio. You spend time kind of building that safety in that container. After that's established on day 1, this is like a 5-day retreat or so. On day 2, you'll undergo a holotropic breathwork or a Groff breathwork session. So that's 3 hours of evocative music with different kind of tempos and ups and downs. And you have a breather and a sitter, so 15 people are breathing and 15 people are sitting at one time. And you use your breath to drive this experience, which creates this very real, non-ordinary state of consciousness. In fact, when you compare validated measures that look at subjective experiences of psychedelics and subjective experiences of breathwork, they look pretty similar. Sometimes people can't tell the difference. There's probably nuance between the two that could tip you off. but by and large, something's happening just with your breath.
It's pretty fascinating.
Yeah. So people are hyperventilating. The setting is getting people's driving the experience as well. Loud music, drumming, all that stuff. And then afterwards, we have integration groups. And then we have artwork. Often you use mandalas to kind of like, free associate or just draw onto, squaring of the circle or a mandala, and just kind of let it rip, like whatever comes out. That's just part of the integration. So just to recap, you've got community, you've got a breath, you've got evocative music, you've got integration, you've got artwork. Those are kind of the 5 big principles of Groff breathwork. And I think for my preferred retreat is you'll get to breathe twice and sit twice. So a total of 4 sessions, and this takes place over about 4 or 5 days.
What's also specific about Groff breathwork, because people may be familiar with breathwork, you may have done it, you may have heard that term or even heard the term holotropic breathwork. Groff breathwork is really specific in that all 5 of these elements need to be present for it to be considered that.
Mm-hmm.
It needs to be in person.
Mm-hmm.
And you as a breather, so Zach was talking about breathing and sitting. As a breather, that means you are in a contained set. You have headphones, you are completely cared for, you have a mat that you're breathing on. It's very similar to actually what you see in like videos about, psychedelic trials. So you're very held, very contained, very supported. Similar to a psychedelic experience where for that 3 hours, there's nothing expected from you. There are no phones in this area, and you are just with whatever comes forth, which in today's world is really rare, just to kind of have that experience. Even if you don't breathe, and even if you took breath off of it, just the experience of being cared for in that way with someone's attention, undivided attention and caring, is pretty special. But I say that to say Groff breathwork specifically, you need to be in person. It's not anything that you're going to do online or it's going to be led online. It's going to be in person. And there's something in that alchemy that really makes that magical. Breathwork is incredibly powerful.
You start the week not knowing a lot of people, maybe you know some people there, and you end it with you've just witnessed oftentimes some of them as vulnerable moments, and you just met them a few days ago, and you had some of your own, there's just a shared understanding, wow, there's something very human about this experience, something that really is tapping into a deep space that I don't really get to tap into in my everyday life. In fact, quite the opposite. I'm so freaking busy. Who's got time for that, So it can really, it's a potent field, and it can be very impactful from a wellness. And oftentimes people do report, I haven't measured it, right? A lot of us haven't measured it, but people do report feeling, less depressed, less anxious, stuff like that. Again, it's not a treatment, it's a wellness technique. That's getting a lot of attention right now. So.
Well, you said they take their phones away from them. That one is going to cause people to hyperventilate.
Right.
Number 2, after that, they're going to start to hallucinate. They're like, "Where's my phone?"
Do you ever get the vibrations on your leg, the phantom vibrations?
Not yet, but I'm looking forward to it.
Oh man, yeah.
I promise by the end of it, most people though are really sad that they have to go back to their phones.
That's true.
You get really used to it. You're like, oh, this is really nice. I get used to it.
Yeah. No, I actually, I'll confess something. I did a 3-day retreat out in California that was none of that, was just a deep psychological, lots of therapy, and took away our phones. We couldn't have there was no radio, no TV, unless there was just some sort of emergency. But it was interesting. So after that 3 days, like the first day felt like probably a week, because what were you doing? You're looking around like you're literally off of drugs, or you're trying to decompress off it. By the time Monday rolled around and they said, "Oh yeah," so my therapist went to go hand me my phone, and I go, "I don't want that thing." Like I literally had a visceral reaction of, I do not want that. Whereas that was not something I was expecting to have happen, but pretty interesting. I mean, there's definitely a negative effect happening. So what's that?
Thank you for sharing that. I mean, that's significant,
It was one of the hardest and one of the most rewarding experiences in my life.
Yeah.
To be perfectly honest, it was very, very difficult because you knew you were going in and you knew that you were going to be walking into memories or thoughts or feelings that you just had been covering up for decades, literally. And then, you're leaving the entire world behind. I really felt like I was walking away from everybody, but it was like 3 days and it was one of the most beautiful settings ever. So what are you going to do? It really did allow you to connect some of the things you're talking about, just really to connect with your inner person and just to think through some things. And so that space, I think I would tell you, probably everybody needs and deserves just something like that experience. But I wanted to bring up and turn it a little, speaking about personal, just turn it a little bit more inwards on the both of you. And I can only imagine that psychiatrists like yourself, they carry a lot of emotional weight. Maybe you don't, I don't know. But, Zach, you said you care a lot about the patients you have, so how are you setting up boundaries to protect your own self, or what do you do to care for yourself when you're taking the load of a lot of what's happening with your patients?
Yeah. Yeah, it's really hard, honestly. And I think as I've gotten out of residency, I've become more aware of how much it really does impact me. I've done a lot of breath work, right? I've experienced that type of non-ordinary state of consciousness. That's changed me, right? It's helped me kind of hold these types of tensions and stress more loosely with an understanding of, what I can do and what my limitations are. And I think overarching all that for me personally is, I was raised Catholic. I'm not a practicing Catholic, but I did reconnect with a sense of spirituality through these experiences. I wouldn't define it. I wouldn't give it a name. I wouldn't say I go to this congregation or I'm this religion. It's just this sense of feeling connected to something much greater than myself. And that has allowed me, I think, to hold my day-to-day stuff much more loosely. And I'll also say, lastly, I'm a father now for 4 months, first time ever.
I was going to say, if there's nothing that connects you to something bigger than yourself, that's it.
Oh my God, everything's changed. So I'm living that right now. But, I'll be honest, I feel more empathetic with him, now that I have a child. But empathy carries a lot of potential harm too. If you're constantly feeling empathetic, it will burn you out. There's good data for that. So, hopefully that kind of answers the question. But I will say, aside from being a father, I think reconnecting with my spirituality has helped me hold things a lot more loosely. And again, I wouldn't define it a denomination or belief or whatever. It's just this sense of something, I'm not responsible for everything. There's something much greater out there, and I can continue showing up each day and doing the best I can and helping in the ways that I can. Yeah. And then giving myself time to hug myself and, cry when I need to as well, and feel my feelings. So, yeah.
Well, I think being able to see outside that, have that to help bring you out of the gravity of the moment you're experiencing right then. Right.
Yeah. Totally. De-blend. I like that word, defuse from those really intense emotions. Also, good therapy works great. But anyway, so.
What about you, Sarah?
Yeah, I mean, I would echo good boundary. So yes, let me preface this by saying I have not yet gone back to work with a new child. So
that's therapy in itself, right?
There will be many new tools in the toolkit following that, already dreading it, crying about it. And I mean, some of these things are, us having to have boundaries, right? We could literally talk about patients all day and work all day, and that has happened to us. And so, boundaries around how much work we're going to bring home and how much we're going to talk about it, or how long we each get to vent, venting to other people than each other, especially working at the same institution, that can really be challenging. And to be fair, this is something we have also navigated. We trained in residency together. We were at the last institution together. So kind of that is something that we've navigated. How do we support each other, and how do we have kind of boundaries in this? But I think breathwork has really been a big part of that for me. One of the things we didn't mention about breathwork, which is it's a very somatic kind of bottom up experience, right? It's not like you're going in. I've done a lot of therapy, done a lot of different kinds of therapy. It's a lot of talking, and talking can be great, can be super helpful. But for those, that might be more like myself, that come from a background with a lot of trauma, starting at a really young age, talking doesn't really get at that. And, there's a really strong felt sense of whether it's the felt fear or the felt pain or the felt trauma in the body, but the felt sense is what a lot of us are struggling with, in the day to day. And breath work gives you a chance to be with that felt sense, to make it bigger, to explore that. And, really what you're learning to do is kind of to turn off that thinking brain, that executive function, that cognitive function, and just be with and allow whatever comes up. So, I've had lots of preconceived notions around certain pains I've held in my body and what that means and the story I have attached to that and how it got hurt. But then the things that come forth, in breathwork are much different than the story that I was attached to. And I will say that creating that space for myself on the mat, remembering that I'm a human and that, all I can do is try to kind of heal and work with my own wounds, so that when I'm in the room with someone, that I can try to show up as cleanly and clearly as possible. And I'm still a human. But kind of working with those experiences and being a human, allows me to sit with the pain more with others. Because at the end of the day, we're all humans trying to walk each other home. Being a psychiatrist right now and today is really hard because people are suffering in ways that we can't help and we have no control over. And it's really humbling to have a tool like this, because ultimately that's what we want, is to be able to provide the space for others to heal in this way. And I think getting out of my own way and doing my own work has been the most helpful tool to continue to have longevity in this work, which is, I can't save people. I'm not a hero. I can't save anyone. But I can try to, care for others as best as I can, and to know that I'm a human and to be a human in the room.
There's not a lot to say. I do have actually two questions left, but that I just so grateful for you sharing those thoughts on that, and just that very raw element to both of you, genuinely. This show is really centered around letting folks like yourself and physicians share their stories. But one of the things that Chris and I have consistently seen over the time that we've worked with y'all is that just the idea that the physicians are always taking care of other people and rarely have time to take care of themselves. So for your colleagues who may be listening right now and struggling with their own mental health, but hesitant to even seek that, what would you want them to hear today?
I mean, first thing comes to me is that if you have any questions to us about breathwork or anything we talked about today, please reach out. I mean, we have these conversations all the time with other professionals. We didn't really go into it. We were huge advocates for mental health awareness in med school and residency. So we're pretty well versed at talking with other prescribers and physicians. So, I mean, I would just extend that out as an invitation if anyone wants to talk with us.
That's actually kind of what I didn't mention that earlier. That's actually kind of what radicalized me to psychiatry was, when we were in med school, I had this idea that this was going to be where people get mental health and we understand it because this is medicine. And I was so enraged when I found out how wildly unsupported we are as medical students that, just the data is that we are 40% of us have depression, 10% of us are suicidal, when prior to med school, we were age matched with the population, without these problems. So specific to medical school, there are some challenges. So that said, please reach out if you have any questions. Yeah.
But I think it's important to remember that healers, we could use the name healers, and healers come in a lot of different varieties. We're psychiatrists, we're healers, medicine doc, internal medicine is a healer. There are non-physicians that are healers. But healers in general, we do tend to share one common trait, which is we're not great at feeling our own stuff, but we're really good at helping other people and holding space for other people to feel their stuff. And so I say that compassionately and to normalize it and just say, hey, you're not alone. And as a function of being such a dedicated healer, it's so easy to kind of forget about our own stuff, and it's so common. So the invitation is to start to lean into that. And if therapy is too much or something, look at a wellness route, right? Look at a breathwork retreat. They're happening across the country. Look for support groups. But I think I just want to normalize what you're describing, Paul. And we've seen the data. Sarah just mentioned the data. There are definitely mental health challenges and burnout challenges in medicine. And I think it's a pretty normal experience. So you're not alone, even though it could often feel that way. And so reach out either to us or friends or colleagues. And, if you're on the fence about finding a mental health prescriber, that's totally normal. Or finding a therapist, that's totally normal. And I would just say, take a chance. Be creative.
Yeah, there's definitely an effort for us to try to help destigmatize that.
Yeah.
I would say one of the things I would want people to know is, especially as a woman, it's going to be put on you individually that you are the problem, that you are burned out, that you are not charting efficiently enough, that there is something you are not doing that is the barrier to the key to your happiness. And if you can just figure out that one thing, often a solution somebody's trying to sell you, then that's going to be how you're no longer burned out and you're no longer depressed and no longer anxious. And so I would say reach out, but be also mindful about who you reach out to. In today's day and age, you reach out to administration of potentially your, department. It may or may not be supportive, right? It may be things like wellness lectures at 8 a.m. or, things that maybe are well-intended, but do not land with the results that are needed. So really reach out to people that you trust. I personally had found that being kind of wise but vulnerable with where I was at and what was going on one of the things in our training, we were really transparent about the fact we were in therapy. Nobody else in our program talked about that. And we made a really big effort to be really transparent about that, to destigmatize that for other trainees that work with us to hopefully help them to get into therapy. So like talking about what you are doing may actually bring you some unexpected alliance and other people that may share their experience, kind of, how they're going about it or what they're doing. As well as, Zach mentioned that there are several wellness modalities. The one thing I would say is that it can be really easy to get into the trap, especially when you're a physician that is, a healer, that this idea that we're always broken or there's always something that we need to be working on, and that we're in this sort of capitalism fueled like wellness industry, that there's always something we need to be optimizing and making better about ourselves. So, I would really encourage you, if that's where someone is to maybe settle and take a little stock over like, what are your values and what are the things that you would like to grow or see change, so that you can target with the time that you do have to target kind of effectively what you want to see change. So maybe that is, exercising 10 minutes a day, or talking to people that bring you connection, or going to therapy. Like, it can be really different. But I think in my experience of being overwhelmed and burned out, when you reach that point, you're kind of just reaching for anything that anyone tells you is going to help. And you can really further burn yourself out. So kind of using your wisdom and your intuition, and coming back just to that reminder that it is not you. The system is designed to, pull as much out of you as possible, and that you are the product to be broken down. And so you have to protect you, because no administration, no program director, no boss, no one is going to do that for you other than yourself. And so you have to get clear on what your values are. And then, as Zach mentioned, as the wounded healers, we're to lean in, right? This isn't something that's going to go away. If you get enough sleep, or you get enough time off, or you take enough PTO, what drew us to medicine, right, is the desire to heal and to connect and help others. And so that's not something that's going to go away by nature of the job. So to lean in and get curious about what are the things that are contributing to it. And that's really where therapy, coaching, a mentor, a clear-eyed friend might be helpful. But to really understand those barriers.
There's one small thing I could add. What I've noticed with healing in general with people, it does seem to boil down often to connection, whether that's connected with one's true self, whether that's connected with community, universe at large, whatever. I think the more that you can try to lean in connection and it feels safe, over time, I think the more better you'll feel, quite frankly. And I think we kind of miss out on that in society a lot, especially as we were talking earlier. We're just constantly on our phones to be connected, but in a way that doesn't really have the same, I think, effect.
And I think it's hard connection as physicians, because we expect a lot of judgment from our peers, and so I think that makes some really specific challenges at times when you're trying to talk about these specific things. Yeah.
Sage advice. I really, I don't know about Chris, but this has probably been one of the most enjoyable conversations that we've had. Before we wrap up, though, we do have one more question, and that is that the name of the show is The Patient Physician. And so our curious hearts want to know what that means to you.
The patient physician.
I thought of this, actually.
You knew this was a trap?
Yeah.
No, I didn't know, but I was like, well, we met you guys through PRS. I think for me, I was going to say the key to a patient physician is trusting an index.
Trusting John? I don't know.
Trusting John. Yeah. Hi, John. Thanks, John. But yeah, why don't you do you want to?
I think you don't have an answer. I can say John first. Yeah. So I think it means many things, but I really think, recently my experience of childbirth and being a mom for the first time has really shaped this. I will be radically candid and share. I had never been a patient before in an unexpected circumstance. So I had only received routine care in my life. I had been very lucky to be healthy. So the delivery of my child was the first time that I had ever really been in that position of like being a vulnerable patient with something unexpected happening and, things wildly beyond my control. And I think that's the crux of being a patient physician, is to put yourself in that vulnerable scenario. That's something I tried to do. I had imagined before. I tried to be as empathetic as possible to, imagine my patients, what it was like for them. But until I was truly in that vulnerable state of being a patient, there was just something tangible I couldn't quite get to that now I know is going to affect how I show up for my patients. And so to me, that lesson is to live, to be alive, to live life, and to be, whether that's a patient with my physician or just to be alive and to create experiences, that are making me a human being. Like that's what is going to allow me to be a patient physician, I think. So that's my answer.
Zach, you're wishing you went first now, aren't you?
I am.
Yeah.
I think for me,
really, that was off the top of your head. Wow. Yeah.
I think for me, being a patient physician means taking a breath each day, each moment, and being in the moment as much as you possibly can. I have something behind me from a friend. It's the most accurate clock in the universe, which is, it's a funny, anyway, the time is now, right? It just says now.
There are no hands.
There's no hands. The time is now. Most accurate clock in the universe. So, but I really feel that way. I think the more that you can be in the moment, the more present, the more you can make, enjoy each moment. But it's not just about having enjoyment. It's also breathing and making space for the negative emotions as well. So just all of it. The more that you can breathe, the more that you can be in the moment. I think the more you can, for me, the more that I can adhere to that principle, it kind of seems like a lot of day-to-day tensions and stuff will, kind of melt a little bit, and I can think more clearly and feel more connected. Doesn't mean they're gone. They'll still come back. I'm just a human. Tomorrow I'm going to wake up probably stressed out about work or something. It's normal. But I think, though, if I can remind myself, take a breath, it's just temporary, like be in the moment, it seems like things have worked out nicely. So, and that's something I've learned in the last 5 to 10 years. It's not something I've lived with my whole life. That's for sure. Yeah.
Zach, Sarah, thank you for helping us create what I think is a really memorable episode, and thank you for joining us. To learn more about HS Psychiatry, check out the links. We'll put them in the show notes. And to our listeners, thanks for being a part of the patient and physician community. If you enjoyed today's story, please like, subscribe, or even share your story with us, because there is somebody patiently waiting to hear it.
Thank you all so much. It was wonderful being here today.
Thank you. We enjoyed having you. Thank you.
Thanks, really quick though, if you're interested, if you did have that person that worked with you, with a husband with PTSD, there's a documentary out right now on Netflix. It follows 3 veterans that went to Mexico and did ibogaine and DMT for their traumatic brain injuries, and it follows as well a little bit
for the PTSD.
They all had TBIs, I thought.
It's a great documentary.
The Stanford group also did some, they had done some research on that. So I don't know if that overlaps with her at all, but if you're interested in that, it's
maybe.
Maybe
now I'm super curious.
Yeah. Thanks for sharing that.
Yeah. It's called In Waves and War. It's, it's making the rounds right now. It's pretty good.
Awesome. Thank you guys. We appreciate having you.
Great to meet you.
Thank y'all.